my introduction, but my name is Ella Nuttall. I'm the Head of Strategy at NHS Select, and I'm going to do the brief intro of what you can expect today before handing over to Katie and Claudia. So the webinar is going to be an hour and a half. We will make sure to end on time, as always. We are recording it for people that are unable to join, but also if you're interested in accessing the recording afterwards or sharing with colleagues, you'll be able to find it on that Teams channel that you should have been added to. And we will also circulate the slides after the call via email to anyone who's signed up or attended. And also if there's any links that we share in the chat or other things that other people share, we'll also collate that into that email. So don't worry about taking notes unless you want to. And then we do have time at the end, as usual, for Q&A. But if you've got any questions throughout, please do feel free to put those in the chat. And then finally, we're going to be using the Teams polls function to get your input on a few things. So when you do see a little poll pop up, please do vote. And it is all anonymous. In terms of our agenda today, and hopefully this is what you are expecting, so we're going to start with understanding nitrous oxide waste in maternity settings, move on to how you can measure clinical use in maternity and some of the challenges associated with it, provide examples of waste mitigation actions for high clinical use areas like maternity, and hear from 3 trusts who are going to share their case studies of their programmes of work. Then we're going to go into a breakout discussion, which is a bit different than the live webinar format we've done to date. And in these discussions, we're going to collectively think about the possibilities together. And then finally, we will have that chance for Q&A as well. As you would have seen in the comms, and if you've attended these webinars before, so NHS England, NHS Select, and UCL Partners are running these series of webinars from January to March to support NHS Trust to design and implement nitrous oxide waste mitigation activities based on the nitrous oxide waste reduction toolkit, which is planning to launch shortly. So you've got colleagues from NHS England, NHS Select and UCL Partners on the call. And we are also lucky to be joined by Mark from Hull University Teaching Hospitals, Amy from the Newcastle upon Tyne Foundation Trust, and Laura from King's College Trust. And they're going to be sharing their case studies and thoughts a little bit later. And just a reminder, so we've got 10 webinars in these series, 3 are pre-recorded and 7 are live. So please sign up to any if you haven't, and also check out the recordings to the live ones that have happened already. And as we mentioned a few times, we're purposely not repeating information across the webinars. So if there is something that is of interest to you, but you haven't heard it in the webinar, please do look back at the previous ones recorded, as hopefully they'll address it. And then we are also doing 2 general drop-in sessions. So these are really broad, open sessions where you can bring any general questions or challenges you've got related to nitrous oxide waste mitigation. And we've got our first one coming up this week on the 20th of February. So please do drop in if you've got any questions at all or any things you would like to get input on. And in terms of how these webinar series have been designed and structured, and if you've attended, you would have seen this. So they aim to sequentially follow the nitrous oxide waste reduction roadmap that you can see on the slide. So starting with ensuring understanding in the context of the NHS, moving to initiating efforts and setting up governance, and then on to ensuring supply of gas is aligned to clinical use, which we're focusing on at this moment, and then on to continuing optimization of systems finally. And you can just see on the slide a recap of the webinars, both the pre-recorded and live ones that we've had so far. So our 2-part introductory webinars, which are pre-recorded, and they're only 15 minutes each. So they cover how nitrous oxide and nitrous oxide oxygen mixture are used in the NHS, where waste occurs in the system, the high-level case for change, and an overview of how to deliver waste reduction projects in the NHS trusts. Then we had our Getting Started on Reducing Waste live webinar, which is recorded and available. And this covered the key stakeholders who need to be engaged in your project, the messages you should deliver to stakeholders such as the Medical Gas Committee and other senior leaders. In our Developing a Waste Mitigation Action Plan webinar, we talked through how to develop a structured plan to reduce waste in your trust. And finally, in the last webinar, we focused on moving from action plans to implementation outside of maternity in no or low usage areas. So what I'm going to ask, again, if you've attended one of these, you would have had this already. So we're just going to do a real quick poll to understand what stage your organisation is at. So I'm just going to launch it. So it should appear up in front of you. So this is just to get a feel who we've got in the room. It is all anonymous, so please feel free to be open and honest. And once you've clicked your answer and submit, you should be able to also view the results of others. So again, it's just really to get a feel where you're at, and pick the option that most aligns with where you're at. It could be you're in the middle of two, or they don't quite fit. Thank you to those that have submitted. And so we've got probably our highest percentage at the moment is at number 6. So those that have started implementing waste mitigation improvement or optimization activities. But we've got a few colleagues who are also earlier on along. Right. Right. So if you haven't had a chance to submit, if you'd be happy to just quickly submit your response. Again, this is just for us to understand as we go through who we've got in the room and make sure that we tailor things in the most helpful way to you. Okay, just in terms of the objective of today's webinar, just re-get my slides. So the purpose of this session is to explore practical ways to move from planning to action in reducing nitrous oxide waste in maternity settings. And this session is really about exploring possibilities, sharing insights, and working together to shape effective strategies. Before I hand over, one final poll that I'm going to pop up, and hopefully, again, it will appear in front of you. So this is what we like to do, is just a pre and a post, so post at the end of the session, confidence rating, to understand how you would rate your own confidence at this particular topic. So how confident do you feel at starting waste reduction activities in maternity? Again, completely anonymous. It's just to get a feel, and then we will do a post measurement as well to understand if maybe people have moved along the scale either way afterwards. Thank you to those that have responded. I can see we've got a range of confidence, but actually most people, interestingly, rating themselves as not confident. So we hope throughout this session we'll be able to help answer some questions and hopefully help improve that confidence rating. Great, so that will stay live in the chat. So if you haven't responded, please do, but I will hand over to Katie and Claudia.
Thank you, Ella. Oh, so reflecting on the confidence levels in the chat, I think this is the reason why we wanted to do a specific webinar on maternity, because I think a lot of people are confident in anaesthetics, ED, endoscopy, all of those clinical areas on how they might reduce waste or reduce the amount of emissions from internox in maternity. Sorry, that it's a lot. People are a lot more confident in those areas compared to maternity, and we, in developing kind of this content and the toolkit that we have developed, have defined maternity as a high clinical use area. So, Katie, if you just click through. So we've separated in and you might have seen this from our other sessions, that in our trusts we have areas that have a pipeline supply but they don't use it anymore. And it's a very simple activity to decommission that pipeline. We have areas that are a low clinical use, which is more often anaesthetics, emergency departments, endoscopy, and sometimes dentistry, and maybe even sometimes maternity, where the gas is occasionally used. But then we also have high clinical use areas, and this is somewhere that it's used frequently. Most patients need it or use it. There's often an extended duration of use over several hours per patient. The requirements are unpredictable, but it is continuously kind of required. And there's also limited alternatives clinically. So especially for Entonox and maternity, we know that it's a great option for both midwives and patients. And so it's kind of a scary gas to address the waste in maternity settings just because of those factors. So we're focusing on maternity today, and hopefully everyone feels a little bit more confident in knowing that they can do some activities to manage and mitigate the waste that occurs in maternity systems. So just to recap on how waste occurs, and a lot of work has been done on medical gas pipeline systems to understand this, but not as many on Entonox. So I think a lot of what we're kind of assuming of medical gas pipeline systems for Entonox comes from our understanding of nitrous oxide. So trusts have done a lot of work to understand how waste occurs in these systems, and they've found that they can occur across many points. So you've got the manifold connections, which are down there in the basement, often. You've got the terminal units, which come out of the walls, and that's where we get our gas from. You've got the isolating valves. They sometimes can have little micro leaks, or where you can switch the pipe off in a certain area. The pendant connections and anaesthetics sometimes have leaks. Sometimes even the anaesthetic machines can have leaks, or the medical equipment that the pipeline is attached to. There can very occasionally be actual pipeline damage, although that's unlikely, and I think most engineers would probably know about that. And then sometimes there's parts of the pipeline connection. Then there's also parts of the system that contribute to waste. And often that is having an oversized system where the clinical need has not been kind of understood before it's created. And then stock management can actually sometimes mean that we're overstocking and wasting more Entonox or nitrous than we need. And often there can be all of these little bits and pieces can add up to, they can be tiny bits on their own, but when you add them all up, it can be extreme amounts. And what you'll hear from Hull and some of the other examples is that addressing just one part of the system can actually significantly reduce the waste. And in maternity, it might not necessarily mean turning off the manifold, but there are lots of different parts of the manifold system that contribute to waste and we can address. You'll also see further on that you can actually also test out maternity without a medical gas pipeline system. Kings will give an example of that. So that is just a bit of a summary of how this waste occurs. Another thing just to note is, and I think again this comes back to our confidence levels in addressing this problem, but we have seen quite good progress on pure nitrous oxide emissions reductions over the last few years in the NHS, and there's been a lot of activity in this space. So with nitrous oxide, we use about 30 million litres a quarter across the whole NHS, and that is about 14,000 tonnes of carbon equivalent. And we've seen about a 20% reduction in the last 2 years of nitrous oxide use. And many medical gas pipeline systems have been found to be wasteful. Most places with low clinical use have been found to move to a portable cylinder system completely acceptably. And there's also been some clinical changes. So, there's quite modern practices of anaesthetics that don't require as much nitrous oxide anymore. And as I mentioned, there's a lot of work going on in this space and people are really confident with it. But actually, I think what we've found is that Internox or nitrous oxide oxygen mixture, which is a significantly kind of bigger contributor to our carbon footprint. So there's about 40,000 tonnes of CO2 equivalent a quarter used in the NHS, which is 160 million litres. That's something that hasn't been addressed as much, and that's kind of why we're talking today. So there's been a steady volume of use over the last 2 years, and many places have a medical gas pipeline system for maternity. And we know that Internox, especially for maternity, is an important part of the clinical pathway. And so it's about maintaining access to that gas while also seeing how we can reduce the waste. And to be honest, we've got some really great examples of projects going on today, but we haven't seen widespread adoption of these projects to reduce Internox from our conversations with the Trust. And it'll be great to hear about anything that anyone else here is doing. So we'll hopefully share some of that later on. And finally, with Internox, sorry, Katie, it is quite hard to understand how much clinical use is actually, how much gas is required. What is the right amount of Internox that we need supplied? With nitrous oxide, it's really easy because you've got an anesthetic machine and you can kind of test it more easily to understand the clinical need. But with Internox, because it's a continuous delivery, it doesn't go through any machine to test the volume of gas used by patients. It's really hard to compare the clinical use to the procurement. So that's a challenge that I think hopefully we have some ideas for figuring that out in this session. So just a bit about the context as well. So what we've found from talking to people who are starting to think about Internox in maternity, what are the challenges? So one of them is that the infrastructure and physical constraints. So we know in maternity, you have limited space potentially. You might not want to have a big cylinder clunking around the room when there's a lot going on in that clinical process. And there's a high usage of the gas, and so sometimes you might need to change it over a lot more frequently than, say, in anaesthetics. So that's kind of one challenge that we've heard has been something that's like, we're not going to do a cylinder option because it won't work for the infrastructure. Another key point is that there's not really any alternate options for Internox. It's a good drug for both midwives specifically and obviously patients. And so there's not an alternate option like there is in anaesthetics or ED or endoscopy, where there's different drugs that are available to kind of provide the same effect. We know there's also workforce and safety concerns around Internox, and we'll talk about that a little bit in the next slide, just setting the occupational exposure issue and kind of leaving it out of scope for the discussion of this chat, this session today. But knowing that is also, something that is part of this picture and that can be a challenge in implementing any changes or addressing any changes. We know that there's implementation barriers, like I mentioned. There's a difficulty to actually know what the clinical use needs to be or is compared to the waste. It's a 24/7 service in most maternity services, and very busy and overstretched staff. And also there's, existing workflows and existing staff and patient kind of considerations that need to be considered. So we know that there are challenges in doing this work, and just want to acknowledge that up front and hopefully provide some ideas for how those might be overcome to reduce waste. And just going back to kind of the scope of this discussion, and I guess putting forward the scope boundaries of what we're talking about. So we are going to discuss how we might measure clinical use in maternity settings, and that enables us to see, is what we're using the same amount as what we're buying? And what we've seen in nitrous oxide is that that's often hugely disproportionate and it's quite imbalanced. So we give some ideas for how you might measure clinical use in maternity settings and therefore identify the waste. We're also going to talk about reducing upstream waste in the supply system. So if we go back to our little map of the, not actually go back, Katie, but if we think about the map of the hospital and all of those different components, it's the upstream elements that we're thinking about. How can we really reduce the waste and optimize our clinical use and reduce the amount we're purchasing, but not the amount we're needing and using in clinical settings. What is out of scope today is discussing any clinical alternatives to Internox. So we think it's a whole nother discussion and kind of it's more of a downstream rather than upstream waste reduction. So it's literally it would be changing what we use, and we don't want to kind of muddy the water of this discussion by talking about that. So we'll leave that out of scope today. The second thing that is out of scope is cracking. So you might know of catalytic destruction technology, which is something that some people have installed in their hospitals, and we, recognise that it's a downstream waste management approach, but it doesn't remove the possibly 90% of the problem of leaking pipes or waste in the system. So we're leaving the cracking technology out of scope today. And then occupational exposure. So as I mentioned, we know that is something that is particularly of concern in maternity. And again, it's kind of a downstream impact of nitrous oxide being frequently used, or Internox being frequently used in maternity. And we're going to leave that out of scope of discussion today because, again, it's quite a big side discussion and has a lot of considerations that we could go into. But I will say there is good guidance from NHS England on occupational exposure management, and I'll make sure I add that into the chat after this. Cool. So, as I mentioned, today we're focusing on maternity. And if you've been in our other sessions, you'll remember that we have this little waste mitigation action plan for our demo hospital. So Hospital 1 has main theatres, which we've dealt with in a previous session, and it also has a birthing unit, which is attached to manifold B, and that's obviously got Internox being supplied to it, and it is defined as a high clinical use area. However, for this area, the clinicians have said that they're happy to try out a portable cylinder system. So we'll talk more throughout the session about what that looks like. And then in Hospital 2, we have another birthing unit, which is attached to manifold D, which also has high use, and they would like to keep their manifold. But there's a consideration of that manifold also being linked to the emergency department in Hospital 2. So that's kind of another example of some of these complexities in the infrastructure, and we'll talk through that throughout this. So I am going to hand over to Katie, who's going to talk through some of the implementation aspects of this process, and then we can go into a breakout room.
Thanks, Claudia, and hi everyone. My name's Katie, and I'm an implementation manager at UCL Partners, supporting the development of these webinars and the subsequent toolkit that NHS England is publishing later this year. I also, in a previous life, was at King's, project managing the work that was done there with Laura and other colleagues with nitrous oxide and Internox waste mitigation. So threading through some experience of doing this work in the next 3 slides. Also, I think it's worth saying that there are many ways of saying this gas. So we officially are referring to it as nitrous oxide oxygen mixture in this presentation. I suppose, what's the word? Anecdotally or informally may also refer to it as Internox and also gas and air. So just to clarify that we mean the same thing in case we divert or change up the name of this. But I'll do my best to call it nitrous oxide oxygen, just a slightly wordier than perhaps some of the other names. But yeah, so going back to what Claudia was saying about understanding use in the maternity setting, really challenging. Not impossible, but challenging. And the reason why we think it's important is going back to the beginning of this project and what's it all for. And the slide we've shown previously at other webinars, but really thinking about the fact that this project is all about aligning the supply of the gas, whether that be nitrous oxide or nitrous oxide oxygen, to clinical use, to the needs, the appropriate needs of the clinical department using the gas. So a matching game, effectively, to match what we plug into the system to what is taken out for clinical use. So before, perhaps your system will look a little bit like this. For whatever gas, for either gas, where lots and lots of gas is being supplied into the system, and it's actually disproportionate. It's much greater than is used. So therefore, there's a waste in that system. So during the project, during the initiatives, rolling out changes to better align the supply that's being plugged in on one side and what's being used clinically, to really try and match that as much as possible. I think waste is a challenging thing to completely get rid of, and I would challenge anyone to know for sure if they've managed to completely eliminate all gas waste from any system, but to really match it as much as possible and really take steps that will remove the majority of the waste out of the system. Hence also why we're focusing on upstream waste today, because we know that is where the majority of the waste sits in the supply system for nitrous oxide oxygen. And then a little note on, after doing this work, it's important to consider the optimizations that will need to continue. So that the fact that this work has a life after doing the doing, and that there will be several different interventions and things that will require constant changes, maybe behavioural changes. Perhaps Amy and Mark will talk to that later, but also the idea around maintenance and really ensuring that any system is sustainable, so it is able to kind of meet future needs without triggering more waste then, and also sort of making sure that we're continuing to be as efficient as possible. So this is really kind of the visual of what this project might look like, and perhaps you're at certain stages of doing it and this resonates. But going back to the idea of measurement, so a key challenge that we face in traditional measurement approaches is that they don't really give us the full story. So standard leak tests that aren't pressure tests often miss significant waste. This is what trusts have shown us, and from my experience too, running standard tests do not necessarily show that there is waste in the system, which is obviously problematic when you're trying to evidence that case in order to motivate change. And procurement data can show high turnover. So I think, and maybe Laura will talk to this later, but I think a lot of the work that was done on gas and air at King's was really established from the fact that procurement turnover was so extremely high, and it felt disproportionate. The instinct was there that it felt disproportionate to clinical use, but it was only after then running a few tests and measuring, which I'll talk to in a minute, was that confirmed. And the fact that the complex system, the pipeline is quite complex some of the time, depending on the size of the building, the age of the building, the age of the medical gas pipeline system, that the systems can be challenging. And as Claudia mentioned, the flow is continuous, so it can make quite thorough testing difficult. It's needed 24/7. So that also sort of leads into why clinical use is hard to quantify in the maternity setting. Demand valve systems, so that image on the right hand side, that doesn't measure actual delivery. So unlike the anaesthetic setting, there aren't machines where you can pull off data as to how much usage there may have been. Usage also differs, going to the last bullet point now, patient to patient, and that the way that the supply and how a patient might use gas and air, nitrous oxide, oxygen really differs. And there's a gap between supply and real usage, so we don't really know what that is. So this is less to do with measuring waste and more to do with making sure you're aligning your supply with use. So this isn't really about sort of how you establish your levels of waste, and more to do with how do you know how much you're using, so you're able to make sure you procure the right amount. That's what the measurement and the data can be really helpful for. So in terms of what trusts have done, and this is looking to the UK, but also further afield internationally, there are several different approaches that trusts have taken to try and understand more about how much is being used clinically. The first is trialing of a portable cylinder system. So installing portable smaller Entonox or nitrous oxide oxygen cylinders on trolleys and using that for a short period, perhaps a 2-week test, to really understand then how many cylinders, small cylinders, they were using over that 2-week period in order to understand what that usage looked like. And then being able to compare that to how much typically the manifold would use over a 2-week period, and start to understand maybe how to better align to what was used in the test. There are also location specific or system-wide leak tests, so a various and different number of leak tests that trusts might be able to use. These need to follow health technical memorandum guidelines and require careful planning, definite involvement, as probably does all of this work of a multidisciplinary team of clinicians and porters and engineers as well. But it can help to identify some major infrastructure issues. However, many trusts, and speaking from experience, it can miss waste when things like demand valves are left plugged in. So I think there are some protocols around managing and doing leak tests, pressure tests, for example, such as making sure that no tubing is plugged in on the point of use side to help really get the most accurate results. Some trusts have also used a combination of these two. So, but because I think the big point I'm missing is, we've mentioned this is a 24-hour, 7 days a week service. And to run a test, it's very likely that you're going to need to identify a moment where you're not using the medical gas pipeline system, which is incredibly challenging in a high use service. So what can potentially be done is to use portable trolleys, use smaller cylinders as an approach to enable that medical gas pipeline system not to be used for the period that you're running a test. That's also a possibility that trusts have done. So being able to use a combination of these two to enable you to test the medical gas pipeline system by having a trial of a portable cylinder. So either using, like I mentioned before, using the smaller cylinders, the counter smaller cylinders used during that period, but also running a pressure test perhaps at the same time to help you understand actually if there are significant leaks in the system. There is a paper. There's a link in the slide that's not very helpful because you can't click on it, but I'm sure we can share it. That's quite recent. That's, I think, from Australia. They used something called a high precision flow monitoring method, where they installed a custom flow meter. This was for nitrous oxide. It doesn't mean that the same thing can't be developed for nitrous oxide oxygen, though. In the manifold room, so they put a custom flow meter in the manifold room, so it didn't disrupt the piping in the walls, and it was between the cylinders and on the manifold, and understanding the usage in real time, so able to understand the sort of the continuous data, the continuous flow, and they identify this also requires there to be a period of very, very low to no use. They picked a period of between 3 and 4 in the morning to sort of understand the flow that was happening at that time. No one was using the system. So I was able to equate that as leaks and waste. However, obviously that's challenging in a 24-hour, 7 days a week service. Doesn't mean that can't be done if there is reliance on an alternative method at that time, such as portable systems. And a final option that again I think has come from Australia, is the idea of weighing cylinders to detect waste. So that's really something that's using an as a slightly simplistic graphic there, but it's basically using an electronic scale that can be procured that's specifically for cylinders to weigh the cylinders during a period, again, of minimal use. So when you're not expecting there to be any demand from the system, to weigh the cylinder as it depletes potentially, which could indicate leaks. And I think that the key thing is that there are methods that are available. They do require some planning, and they likely require you to have a process in place that enables you to step away from continuous usage of the medical gas pipeline system in order to test it. But they can really help inform decisions about what the actions might be, whether or not you resize a manifold, whether or not you switch permanently to a portable cylinder system, or you focus on infrastructure improvement. So perhaps, a combination of approaches is the best. And it really only is clear when you're able to test the system and understand how much you're going to need to use over a certain period. And of course, trialing a portable cylinder system, no matter if you're not intending to roll one out, can really help to get an understanding from patients and from staff who are involved in the system from delivery to use, how that has worked and what the thoughts are and experiences may be, to help also inform decisions about maintaining and retaining a medical gas pipeline system. So moving on to waste mitigation actions and case studies. So in this section, we're going to talk a little bit through the actions that trusts have implemented to mitigate nitrous oxide oxygen waste in the maternity setting. And then we're going to hear Mark and Amy and Laura talk through the cases for each of the different hospital trusts that have done the work and find out a little bit more before we go into breakouts. And I can see lots of things happening on the chat. Sorry, I'm not able to my computer's being really funny and not always updating so quickly, but thanks, Claudia, I can see you're on it. That's really helpful. And I'm sure that we can come back to some questions at the end, because there is time for Q&A. So thinking about actions to mitigate nitrous oxide oxygen waste, there are a few that we're outlining here. One is, of course, switching to a portable cylinder system and then decommissioning a medical gas pipeline system. We talked a lot about doing this in the previous webinar. Obviously, it's a very common implementation for theatres, but it can be done in other areas. I think that some maternity units, some birthing units are smaller than others, and there is a possibility of considering how this might work for some that are for some that are the right size, or where clinicians feel that they're open to seeing how it goes. Of course, then decommissioning the medical gas pipeline that serves the area. And I think also when we talk about decommissioning, an action in high use areas is also part decommissioning. So this is something that some trusts have done where a particular area of the maternity unit doesn't actually require wall access to nitrous oxide oxygen, but it is a branch of the medical gas pipeline system that was indeed leaking. So it's a way to quite neatly part decommission to areas that don't need the wall supply anymore due to the fact that the area has changed purpose, etc. So decommissioning if you're converting to a portable cylinder system, but also considering part decommissioning and really ensuring that the system is quite lean and only supplies the areas that really need it. Another option that we're seeing happen is the repositioning or the redesigning of a manifold. So repositioning both of these, really the reason is to really minimize the pipeline length, because leaks are the majority of the waste, and the majority of leaks are from pipeline issues with the pipeline. So really trying to minimize the amount of pipeline that there is between the manifold and the terminal wall units where it's needed for pain relief. So options to maintain and then reposition and resize your medical gas pipeline system, something that could be a possibility. Of course, fixing leaks, I think this speaks to sort of across the system, no matter what kind of system you're implementing, but fixing leaks in a medical gas pipeline system specifically is an option, and we'll hear later about trusts that have done that. That's both at the point of use, so parts of the system that are required that the clinicians plug tubing into, etc., the valves on that side, throughout the piping and also at the other end of the manifold too. So leaks across the system. And unplugging tubing, so unplugging tubing at the point of use. We saw that photo earlier of the demand valve and the tube, so making sure that has seemed to be quite a successful intervention in some maternity units that we're going to talk a little bit about. And no matter what the action, so these 1, 2, 3, 4, 5 potential actions or considerations, each of them can be supported and enabled by the continuous optimization of that system. So thinking about the fact that waste also occurs in expiry of cylinder stock. So no matter big cylinder or a small cylinder, making sure that stock is rotated and that there's a good system in place to ensure that the amount of cylinders on site is really the amount of cylinders that's needed, and reduce waste through expiry. Also, the checking for leaks and the continuous systems around making sure that even in portable cylinders that they're switched off when not in use, etc. Locating storage as another opportunity challenge that we've seen trusts have to think about when potentially converting to portable cylinder systems. I think that the thing here is really around sustainability and thinking about ensuring that you have a sustainable process in place, no matter the system of delivery, and that, you know, decades into the future, the people who are running the system will be able to maintain that it's keeping to be quite efficient. I think that's maybe potentially part of the problem with medical gas pipeline systems, is that we've seen over the decades that they've been in place in some cases that the sustainability hasn't been maintained. So these are our actions. These are our recommended actions for the maternity setting. And I think it's very important as well to say that it's very much case by case basis. There's not a one size fits all approach that works. It's obviously very helpful to understand what's worked in other areas for other trusts, but each maternity setting and each birthing unit will really need to consider what will work best for their specific requirements, their space, their clinical preferences. And I think it's really important to make sure that there's choice and that there's autonomy and decision making around what could be the best things to do to try and reduce nitrous oxide oxygen waste in delivery systems in the maternity setting. So focusing in on the redesigning of the medical gas pipeline system, there are a few things that are required in doing this. And I think that if this does happen, if there is an opportunity where there is a new medical gas pipeline system that's going to be put in, or one that's redesigned, the first thing is to really understand if it's needed. There have been cases of my own experience, where shiny new manifold systems are going to be installed in new buildings, and clinicians are already starting to move away from the manifold system, and connecting up the engineers and developers who are building that new shiny system with the clinicians who don't want it is really important. And so assessing if it's actually needed clinically is the number one thing, I think. And of course, ensuring that they are an appropriate size for the clinical area. So making sure that they match what is needed clinically. So going back to that weighing scale, that the manifold isn't oversupplying, and making sure that the manifold banks are a suitable size. Avoiding excess connections or oversizing. So thinking really about the design of the connection and how it can be the minimum, the least amount of piping between the area that uses the manifold and the manifold itself. So also, I suppose, considering the location of the manifold as well, and really making sure that it is the shortest possible distance. Checking pressure requirements to drive the gas through the components. And designing, I mentioned this, but designing for shorter piping distances. So thinking about where that manifold could be and where it could be positioned potentially right next to a birthing unit to really, really tighten up and really reduce the length of piping between the two. And medical gas committees that we've mentioned in previous webinars, right, in our first live webinar, really they play a central role in the whole of the mitigation of nitrous oxide and nitrous oxide oxygen waste, but they also play a central role in these hospital design decisions, and they really should be ensuring that they're involved in the decision making and the design of any new medical gas pipeline systems that might come in, and that clinicians are also very much involved in how and why this is being installed, and that anything is done across these 5 areas to really make sure that the system is as lean as it can be and as effective and as efficient as it can be. And going back again, there's a health technical memorandum, the HTM 0201, that provides guidance at the moment on how trusts should follow this. Perhaps we can link to that in the chat actually later on. So going back to the example waste mitigation action plan that we mentioned at the beginning of this webinar, you'll see here that we've got our hospital 1, so our birthing unit, and we can see that the clinicians in this case, for this particular birthing unit, that they were happy to transition to a portable cylinder system. So you'll see, going back to the actions that we've, thanks for putting that in the chat, Claudia. If we go back to the actions, we'll see that it was switching and decommissioning, the first 2 potential recommended actions for that hospital 1 that birthing unit decided to go forward with and implement, alongside an optimization of that system. So making sure that the number of portable cylinders matches clinical need, that they are switched off or turned off after use. There's actually another session that we're running on the 13th of March at 10 to 11:30, specifically around how you optimize systems, how you continue to optimize any kind of system, portable or medical gas pipeline. So there's more detail in there if you're interested in understanding more about what those actions might be. And then going to hospital 2, the birthing unit there, we know from before that they share a manifold with the ED department. And their decision was that the manifold is actually quite a far distance from the birthing unit, and that there are branches of the medical gas pipeline system that go to places with low clinical use. So their action there is to reposition and redesign the manifold and the medical gas pipeline system. So going back to the choices here, really thinking about that third one and repositioning it to sit closer to the birthing unit, and also decommissioning branches from it. So we mentioned ED and how they were also served by that manifold. They perhaps are going to use portable cylinder systems, so they're going to stop being reliant on that system for nitrous oxide oxygen, which enables there to be a decommissioning of that branch. And then because that medical gas pipeline system and that manifold would only serve the birthing unit and no other areas, it can be made smaller and it can be made closer to that birthing unit. That's the decision that the hospital has gone with. And of course, then optimizing again. So if you come to that webinar on the 13th of March, but optimizing the medical gas pipeline system, again, ensuring that the stock is appropriate, and identifying processes to ensure that it's maintained, that it's tested for leaks, and that it's fixed as well when leaks occur. So we're going to have a little bit of time now to talk through the case studies. So we're going to start with Mark from Hull. Mark, if you wouldn't mind just introducing yourself and talking through the interventions that you've done to reduce nitrous oxide oxygen waste.
No problem. Thanks very much, Katie. So my name is Mark Bowman. I'm Head of Sustainability at Hull University Teaching Hospitals. We first started looking at this back in 2021, where we looked at our overall footprint of the trust and found that behind procurement and estates energy usage, our anaesthetic gases were our highest source of emissions. And of those, NOx, or nitrous oxide and oxygen, was the highest of all of those. It was significantly higher than other organisations that we were able to speak to at the time. Back then, very few were able to benchmark it. Now we're very fortunate. There's the Greener NHS dashboard. So if any of you are looking for your nitrous oxide or gas and air data, if you go and look on the Greener NHS dashboard, you'll be able to find it there. Unfortunately, the birth data, which is really useful to be able to give yourself an indicator of where you're at, is no longer on there. Hopefully it will be getting added back on, but you may need to either find that from some of the other NHS databases or from your internally within your organisation. That'll allow you to get an idea of how much wastage you have and how you compare to others. When that national data was available, a good figure tended to be somewhere between 120 to 150 kilograms of CO2 per birth. So that gives you some indication of where you could be looking for. We were significantly higher than that, and we're actually administering so much Entonox, unfortunately, we would be killing ladies that were giving birth in our birthing suites. So we knew that we had a real issue, and we knew they had leaks. So we got a multidisciplinary group together. We involved the states, pharmacy, our PFI contractors, because our Women and Children's Hospital is a PFI building, and got the group together, and we discussed that national data. So we knew that we had an issue, shared the reasons why it's important to do something about this, the significant environmental impacts of nitrous oxide, and then worked through the full system from the manifold system through the pipework down to the terminal units at the bed heads. And what we found that we had no leakage on the manifold system. What we found slight leakage on the bedhead units, but the biggest issue was when we were doing those leak down drop tests, was that the actual demand valves or probes themselves being plugged into those terminal units were leaking at such a rate that we couldn't do an accurate leak down test. So we found that actually unplugging the demand valves had a significant impact on our usage of Entonox. So there was no impact on clinical care. There was no restriction of gas to women in labour or others that may be using it. We saw over an 80% reduction in our usage of Entonox, which delivered a significant saving. We put in a protocol so that demand valves weren't left plugged in when not in use, and that was by far the biggest element of the saving. We managed, there were some small leaks. I say that we did replace seals and things, but by switching to that change of practice, it had a massive impact. And it's not only the impact of the gas itself, there's all the additional benefits there that the portering teams are no longer having to exchange cylinders as regularly. There's all those deliveries on the road that's reduced. We went down from over 250 cylinders a month to 33 cylinders a month. There's financial savings from this, and there's very low costs of changing that process. Going forwards, we have embedded that into our med gas committees. So now every med gas committee, there's reports on nitrous oxide and Entonox usage, which allows us to keep a check on these things. And it is something that needs to be continuously monitored, as what we found in the last year, although we'd had the process in place for a couple of years, is that we started to see our usage increasing. And what we found is that people were falling back into previous habits and leaving demand valves plugged into the walls. But by reiterating that communication with staff, we've been able to then bring the usage back down to the previous levels that we'd achieved. So it's definitely something that requires some embedding of ongoing monitoring, and to keep on top of these things going forwards and manage it like any other resource that you would have in the hospital. And happy to take any questions at the bit at the end. I think that was my succinct slot that you wanted.
Great, thank you so much, Mark. That's great. And as Mark mentioned, yeah, we're going to have time for some Q&A after the short breakout. So next is Amy from Newcastle. Amy, if you wouldn't mind kindly introducing yourself and talking us through your work.
Hi, I'm Dr. Amy Manning. I'm an obstetrics and gynecology doctor by trade. I also work 1 day a week on the Born Green Generation project at Newcastle Hospitals, which is looking at reducing plastic and toxic chemicals in maternity care, and that's funded by Healthcare Without Harm Europe. I'm also one of the Women's Health Network leads for the Centre for Sustainable Healthcare. So I just encourage everyone to join that Women's Health Network if you're not already a member. So I had obviously a background in sustainable healthcare within maternity, and then when I found out a couple of years ago how bad Entonox was, realised that this should probably be a key priority. So when I started work at Newcastle Hospitals, I met with our estates manager, Thomas Rutherford, who took me on a tour of the manifold. So I went down to the manifold in the hospital, which I had no idea about. And he took me on a tour of all the pipework through the hospital. And it was amazing, actually, how far it went when you looked at it underneath the hospital and all the way up to the maternity unit. And I also met with Katie Whitehouse, who unfortunately couldn't make it today, but she'd also done a lot of work on nitrous oxide and nitrous oxide oxygen waste mitigation in the hospital. So I was lucky at Newcastle Hospitals, there already was quite a lot of work underway, but after hearing Mark actually spoke at one of our CSH Women's Health Network evenings, I think it was almost 2 years ago now, but after hearing him speak and I heard the savings that they've made at Hull from unplugging at the bed heads in the room, I realised that being an obstetrician, this was a good win for me because it was a very simple project. And if we could get the midwives on side, then it was going to be a very easy win. It was just before November, so I made a N2Ovember poster and publicised it as widely as I could amongst the maternity staff. I made little stickers that went above all the plug-in sites in the maternity, but also went round to the other sites in the hospital that use Entonox. So at Newcastle Hospitals, that was the burns unit they used quite a lot, and also the paediatric ward. And it was interesting speaking to the staff on the burns unit because they said that they already unplug it, and that's to stop patients using it when they're not in the room. And also they don't let their pregnant staff work with Entonox, which I thought was very interesting considering how many pregnant midwives we have who are working with Entonox all the time. So yeah, pushed for unplugging, and then got the details from pharmacy as to how many we were ordering per month. And after 6 months, on average, before the intervention, we were ordering 30 cylinders, so 16,000 litre cylinders a month. And after just unplugging, we went down to 20, so we'd saved a third of our ordering. And with that could communicate that result back to staff who could really see that like such a simple measure made a big difference, and we'd saved I think £40,000 a year. So yeah, it was really about behaviour change and habit. I think, as Mark said, just getting this ingrained that's just part of good housekeeping, really, unplugging it. The only other thing I wanted to mention was in terms of the culture of Entonox, it's very much a culture within the UK use in maternity. And I know that Katie said that wasn't really what we were going to be discussing today, but just to say that it isn't used in a lot of European countries. And, you know, there are alternatives, Remifentanil, PCAs, epidurals, opiates, alternative therapies, which I think aren't pushed very much in the UK. But I think it is obviously something that we should keep in mind. Thank you.
Very true. Thanks so much, Amy. And now finally, Laura from King's. Thanks so much, Laura.
Hi, everyone. So, yeah, along similar lines to what Mark and Amy have already said, we did the nitrous oxide project at King's. As Katie mentioned, she was a big part of it. And when we started to look more in depth into the gases, we knew we had a really big problem with Entonox by looking on the Greener NHS dashboards. So for those who don't know, on NHS Futures, you can sign up and you can figure out where your trust or anything is within these charts. So they have really, really good demographics for your usage in terms of litres, in terms of carbon footprint for nitrous oxide and Entonox, nitrous oxide and oxygen. And King's was way, way, way over to the right, which was really bad. So we were one of the worst in the country. And when we looked at actually what we were ordering in, similar to what Mark said, we realized that actually there's no way we could have been using that. It just wasn't possible. So for context, that was around, we were changing our manifold over every 5 to 10 days, and we were using those really, really big EW cylinders. So that was 170,000 litres of Entonox every 5 to 10 days. So that was just not realistic. So because we'd already done the nitrous project, we had a little bit of knowledge in this area, but they are very different, and Entonox is harder, I'm going to say, but there are ways to tackle it. And in order to establish the extent of our waste, the first thing we did with support from our States colleagues was ran a whole system pressure drop test. So this is crucial because this will show you the extent of leaks. And it's very difficult to do this on an Entonox manifold because an Entonox manifold is used 24/7. We don't control when babies are born. For doing the similar thing in a nitrous system is a lot easier because you have time out of theatre, they have audit days and things like that. So we just realized very quickly that this Entonox manifold had been in position for 20 plus years and had probably never been properly tested, which is obviously a serious problem. So the test showed huge leaks, of course, and we wanted to tackle these as quickly as possible. So the first thing we did is assess all the areas the manifold served. And what was really great is that we realized that actually there's only one place using Entonox, which is of course maternity, and the other two places that it was serving, ED and endoscopy, weren't using it at all actually. ED has switched over to Penthrox, which is also a great alternative, and then endoscopy were already using portable cylinders, so that was great. That meant we could just literally turn isolate those two areas immediately, which we saw a huge reduction in use as soon as we did that, which was great. And that just showed that there was clearly a big problem in that area, but the plan was we're going to turn it off and we're never going to turn it back on again because it's not needed. And then, of course, we had to cap the outlets in those areas as well, which we did with our estates colleagues. So when we then started to look at actually maternity, we wanted to make it as lean as possible. So we started to do isolation in areas of maternity as well. So we actually invested in a G200 machine, which some of you may have heard of. And I'm not going to focus on it too much in this talk, but it's just basically a continuous monitoring system. And we can use those to monitor staff exposure, but we can also use it to measure the amount of nitrous oxide in the air. So we actually just used it on the ward to figure out, like, could we find areas that had bigger leaks than others, like find areas of the pipework. And we found that there was big leaks in places like transitional care, in our recovery, but those areas don't use Entonox anyway. It's not something that's used there. So it was actually really great that we could start making the supply leaner. So we were isolating parts of the branch work that supplied these areas. So the whole while we were making it leaner and leaner, but we kind of quickly realized that even in doing this, we still weren't seeing the massive significant drop that we thought we would. We were very jealous of Mark's graph whenever he showed us. We took a lot of experience from Mark, and he showed us this lovely big drop they had, and we expected the same, and we just didn't really see it. So we basically decided that we needed to shut our Entonox manifold down completely, so that actually we could do a proper carcass test of the whole system, which we knew would take a lot of time and effort, but actually it was worth it. And almost just to sort of say and give the feedback to say, yeah, like this is something that everyone potentially needs to look at to see like what is happening with our manifolds. So we did that. We shut down the Entonox manifolds with the support of our midwives, who were amazing, really on board and engaging, and we switched over to portable cylinders. So we had a lot of midwives who had been there for quite a while, who were on board, but like, oh, we know what it's like to use these portable cylinders. They're clunky, they're not great. But much to everyone's surprise, there is now different cylinders available than were used 10, 20 years ago. And these are the EX portable cylinders. So they're super easy to use. I've even used to plugged one in myself. So you just break the seal and you open the flap and you just plug the piping straight in as if you would to the wall. So midwives were really happy because it was really easy, wasn't going to impact them and their capacity. And these cylinders all go on a trolley, and they're put in every single room that Entonox is required on the labour ward and in the birthing suite. So what that means is you have a cylinder on a trolley. It can be easily moved around. These trolleys are perfect size, so it just fits right in snugly. And the midwives can replace the cylinders as well when they're empty. They have a valve on there that will show you when it's becoming low. And we had a lot of people say, oh, like, how will you like store enough to replace every single one if you have 15 areas and 15 trolleys with Entonox? So for us, we didn't have a huge medical gas storage area, which I'm sure a lot of trusts had the same thing. We didn't have space for loads and loads of additional cylinders. So actually we just kept around 5 in our small medical gas store on the ward. And then the idea was that every morning or at the start of every shift, someone would check all the cylinders and just make sure that actually they were all had enough in them. And if any were low or about to run out, those would be replaced. We just call the medical gas porter and get those replaced. And then the idea is that if there was ever an emergency, if a woman was using it and it had run out, there would always be one in the store that they could grab. And then the medical gas porter will come and replace those. And the system works really well. We actually had one of our housekeepers who was amazing, and she just got really involved, and she was the one that took ownership of it and was going around checking all the cylinders all the time. So you can find that someone who will take ownership of it. I think it's really positive. And yeah, so we also did a really nice poster as well to put on the ward, because we really wanted feedback from patients and staff and engaging patients to understand why we were doing it. So quite a simple poster, just with a simple message around why your enterococs might look different this time around if you've had a baby previously, why we're doing it. But we had no complaints, no negative feedback at all from any of our patients. And we actually did a survey to the staff to gather their impacts. And whilst it wasn't, obviously there was issues, there was no major complaints, no major issues. Overwhelmingly, the results were really positive. Midwives did understand that actually this is probably a better solution for some of our patients. Certainly we heard a lot of positive comments around things like mobilization, because when patients are in the room in a bed, they can't really move because they're attached to this the pipings in the wall. But with the trolley, they can go for a little walk, they can mobilize to the bathroom. So that was a bit nicer for some of them, I think, as well. And yeah, that's pretty much us. We've lot less time consuming for our porters as well, which I think has been really positive. They're much happier with us. I think we made them do a bit of work initially, but overall, much better.
Thanks so much, Laura. I stopped screen sharing because I think now is the moment we're going to go into breakouts. We probably have not so much time as we would ideally like, but I think if we could sort of have 15 minutes or so in the breakout, and then we can come back to the main room and have some more questions. But really the focus of the breakout rooms is twofold. One is to really think about the interventions that Mark and Amy and Laura have shared, and if they could work for you, and what would need to be in place in order for them to work for you. So just have a general conversation about the practicality of that. And then also thinking about what other ideas, what new approaches do you have? If you have any in mind, share them. And also when it comes to measurement too, any opportunities to test something different, and what would be needed for that. So really just to have that discussion in the breakout rooms. So I believe they're going to be set up. Angeline's on it. And I think that we're just going to have two, so split the group in half.
Yes, so I'm just about to click on the button, so we'll see you shortly.
Great, I think everyone's back in the room now. And I think we don't want to do too much feedback now because of the chance to do some Q&A. So I wonder, Claudia and I will go away and tidy up the Miro, and we'll post on the MS Teams that you'll have access to, so you can see the outcome of that Miro. That's helpful for you.
We are good to close. We do also have that general drop-in session in a couple of days if there's any questions people would like to discuss in more detail. So massive thank you to everyone joining, and thank you to Laura and Mark and Amy for sharing their thoughts as well. Have a nice day, everyone.